Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series, where we tackle high yield topics tailored for clinical practice and PANCE preparation. Today we'll focus on melanoma, the most serious form of skin cancer. While it's not as common as basal cell or squamous cell carcinoma, its potential for metastasis makes early recognition critical. Let's break down everything from risk factors to basic management strategies that every PA and PA student should know. Let's start off with some basic pathophysiology. Melanoma arises from the uncontrolled proliferation of melanocytes, the pigment-producing cells in the skin. UV radiation is the primary risk factor, particularly intermittent intense sun exposure and tanning bed use. Genetic predisposition also plays a role. The key takeaway is that almost all melanomas show an initial radial growth phase followed by a subsequent vertical growth phase. The vertical growth phase is associated with a higher risk of metastasis. Next, let's talk about who melanoma affects. Melanoma doesn't discriminate by age, but is more common in adults, especially those with fair skin, light eyes, and a history of blistering sunburns. Individuals with numerous or atypical nevi are also at increased risk. It's also worth noting that although UV radiation is the primary risk factor, melanoma can also occur in areas that are not exposed to the sun. As far as clinical presentation, melanoma can take on various forms, but the ABCDE mnemonic is crucial for identifying suspicious lesions. A stands for asymmetry. If a lesion is bisected, one half is not identical to the other half. B is for border irregularity. Borders can be scalloped, notched, or sharply defined. C is for color variation. Melanomas often present with multiple shades of color, including red, blue, black, gray, or white. D is for diameter greater than 6 millimeters, which is the size of a pencil eraser. And E is for evolution, elevation, or enlargement. Lesions that are changing in size, shape, color, or a new lesion are highly suspicious. And I'll add that a history of an increase in the size of a lesion is one of the most important signs of malignant melanoma. There are various subtypes of melanoma, including superficial spreading melanoma, which often presents as an irregularly pigmented macule or plaque that primarily grows horizontally rather than vertically into the dermis. Another type is nodular melanoma, which, unlike superficial spreading, this one tends to immediately grow vertically, making it more aggressive. You'll also want to keep an eye out for less common forms like acrolentiginous melanoma, which arises on palmar, plantar, and subungual surfaces, or amelanotic melanoma, which is definitely a diagnostic challenge due to not having the characteristic pigment marker. Now, one last note here is to look for the ugly duckling sign. This is an important finding in patients with multiple nevi, and basically, you're looking for the lesion that looks different from the surrounding lesions. As far as diagnosis, early detection is vital. Dermoscopy is supportive, but any lesion suspicious for melanoma should be biopsied. A complete, full-thickness excisional biopsy extending to a depth to encompass the thickest portion of the lesion should be performed whenever possible. Partial incisional biopsy may be acceptable if excision of the entire lesion is not feasible. Now, let's talk about the management. In primary care, your role in melanoma is early identification and referral. However, generally for localized melanoma, the recommended treatment is wide excision with margins based on Breslow's depth, which is basically the thickness of the lesion. Prevention is key when it comes to melanoma. Advise your patients on sun safety measures, including wearing sunscreen, avoiding tanning beds, and performing regular skin self-exams. and high-risk individuals or patients with history of previous melanoma will need regular follow-ups. Here are a few clinical pearls to keep in mind. Number 1. Always biopsy new or changing pigmented lesions, especially those with high-risk features. Number 2. Educate patients about checking hidden areas, like the scalp, the soles, and under the nails. And number 3. Sunburns in childhood significantly increase melanoma risk, so emphasize prevention early. All right, let's test ourselves with some clinical questions. Question 1. A 54-year-old man presents with a lesion on his back that he noticed 6 months ago. He has noticed that it has been growing. Physical exam reveals an 8 mm asymmetric macule with irregular borders and multiple shades of brown and black. He reports a history of significant sun exposure, but no family history of melanoma. Which of the following is the next best step in management? Is it A, observe the lesion with routine follow-up, B, perform a punch biopsy, C, perform an excisional biopsy, or D, refer for Mohs micrographic surgery? I'll give you a couple of seconds. If you chose C, perform an excisional biopsy, you are correct. This lesion is suspicious for melanoma based on its size, asymmetry, border irregularity, and color variation. Excisional biopsy should be performed whenever feasible when suspecting melanoma. Question 2. A 35-year-old woman presents for a skin check. She has a history of childhood sunburns and reports a new lesion on her arm. Exam reveals a 7 mm asymmetric plaque with notched borders and varying shades of brown, black, and red. Which of the following is the most likely diagnosis? Is it A, seborrheic keratosis, B, melanoma, C, dysplastic nevus, or D, basal cell carcinoma? If you chose B, melanoma, you are correct. The history and physical exam findings, including asymmetry, irregular borders, and color variation, are consistent with melanoma. Great job! Thank you for joining me for this episode of the Pro PA podcast. Early recognition of melanoma is essential for saving lives, and as primary care providers, we play a pivotal role in early detection and prevention. Be sure to subscribe and turn on notifications so you never miss an episode. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you next time.